I'm going to walk you through the way I think of my approach to pediatric dysrhythmias. And then what we're going to do is we're going to go through a few scenarios. And after each of those scenarios, we're going to end up debriefing the 6. Basically, I'll take each of you 3 groups of 6, and we'll do scenarios. And each group of 6 will basically, after the scenario, we'll walk through a debrief, and then everyone's going to be able to contribute and be part of it. Okay. And hopefully we'll all learn something from it. Okay. Is that making sense? How is everyone's English? Because my Italian is awful. Right? Stop if I'm using words that don't make sense, which is always a chance at 4 o'clock in the afternoon after lecturing for 6 hours, right? Just stop me, and I'll try and make things clear. Okay. All right. So my approach, right, when I think of dysrhythmias, there's the dysrhythmias where I know, looking at the rhythm strip, that these are patients that are going to be in arrest. They're going to need CPR. There's the patients that I know are going to be they're going to be benign. They're not going to be a big problem. I'm going to have the time to call a cardiologist, call an intensive care doctor, to call for some help. And then there is a group of dysrhythmias where, for me to make a decision about how quick I need to respond, I'm going to need to assess the patient. And really, it's assessing them to see if they're in shock and how unstable they are, right? So there's 3 pots that I put the various dysrhythmias in. So we've talked about the ones that I know are bad, right? Asystole, ventricular fibrillation, and bradycardia, which has a very wide, complex QRS. That's what we call an idioventricular rhythm. None of these have significant contractility. They're all going to need CPR. This one's going to need defibrillation. They're all going to need adrenaline, right? These kids, we know they're going to need CPR. They're really sick. Just a reminder, the kids that look like this, remember that asystole, you might think it's asystole, but it's always a good idea to change the lead that you're monitoring to make sure that there really is asystole and it's not that one of the leads fell off the chest, right? So that's number 1. And number 2, turn up the gain on the monitor, and it may be that it's not asystole, it's actually fine ventricular fibrillation. And that's important because if it's asystole, it's CPR and adrenaline. If it's fine ventricular fibrillation, it's defibrillation, right? Okay, so these ones are easy. They're sick. I know they're sick, they need CPR. These ones, I look at them, I look at the rhythm, I say, okay, this kid could be really sick, but ultimately what I need to do is I need to examine them for signs of shock. Do they have a low blood pressure, a long capillary refill, weak pulses, altered mental status? Do they have signs of severe shock? So monomorphic ventricular tachycardia or polymorphic, right? What we call torsade de pointe, right? These you can be awake and looking around and maintaining a normal blood pressure for a little while, right? But a lot of these kids can also be hypotensive, comatose, right? They can be really sick. So for me to decide what I'm going to do, I need the physical exam. I need to assess the circulatory system. Next. The same thing with these ones, right? PSVT, SVT, they may be awake and fine. They may be comatose and gray, so I need to examine them. Atrial flutter, we see it less commonly in kids, but you do see it in kids with congenital heart disease. And then 3rd-degree heart block, which you guys know if you've had heart surgery or if you have congenital lupus, there are diseases where you can actually have 3rd-degree heart block. These diseases, they may be stable, but they may not be stable for very long, right? So you need to assess them for their circulatory status. And then there's the rhythms where, honestly, it's more important what's causing them than the rhythms themselves, because the rhythms themselves are pretty benign. They're not going to get you into trouble, right? PVCs, premature ventricular contractions, premature atrial contractions, atrial fibrillation, first-degree block, second-degree block. Very few people are going to die from this, but it's more, next slide, it's more that there's signs from that there's problems, there may be problems with the heart muscle, right? Whether it's because of hypoxia, ischemia, electrolytes, all of these different things. So we're going to talk about every time we're looking at a heart rhythm problem, don't just focus on the rhythm and treating the rhythm, but think to yourself, what's the cause of it? Because you need to not only treat the rhythm, but you probably need to treat the cause of it as well, right? Okay. So if the dysrhythmia is so bad that we're needing to do CPR, this is the steps I'm always thinking of, right? So if I'm doing CPR, first thing is, you know what, in fact, as they start CPR, I'm putting the pads on to check the rhythm. And if it's shockable, I'm not waiting 2 minutes to do electricity. I'm doing electricity now. So if it's shockable, shock them now. Shockable and pulseless, right? If they're shockable, if it's a shockable rhythm, but they have a pulse and their eyes open, that's different. But if it's a shockable rhythm, like ventricular fibrillation, the most important thing now is electricity. If we're doing CPR, you guys know that high quality, it has to be high quality CPR. Otherwise, all of this stuff isn't going to do anything, right? In terms of the drugs. So the high quality CPR, adequate rate, right? 100 to 120, good depth, recoil, so no leaning, end tidal CO2 that's above 10 to 15, right? So those things that are telling us that we're doing good chest compressions and we're pushing the blood out to the body and to the heart. Those are the markers that we need to make sure that we're actually targeting. Every patient that's getting adrenaline and remember, if you're in cardiac arrest, every algorithm has adrenaline in it every 4 minutes. 3 to 5 minutes, let's just call it 4 minutes. Okay. So what happens is that it's a common thing, whether it's asystole, PEA, VTAC without a pulse, ventricular fibrillation. Every one of those patients is getting adrenaline every 4 minutes, right? There are going to be antidysrhythmics that we'll talk about in a little bit. And then, like I said, don't just focus on the rhythm, focus on what are the causes, right? Maybe there's a reversible cause that if we treat the rhythm, we'll also prevent them from going back into dysrhythmia by treating the cause. Is that okay? Does that make sense to you guys? So we talked about the lump, putting them into different buckets, right? And then we talked about it's not just about the rhythm, it's about what might be causing the rhythm, as well as making sure that we provide good CPR as necessary, okay? So why is it that some patients deteriorate with certain rhythms, right? Well, some of it is obvious, right? If you've got no rhythm and the heart's just jiggling, like with ventricular fibrillation, no blood's going around, not surprisingly, your patient's going to be unconscious, no pulse, whatever, right? You can have a rhythm, but no contraction, right? You know, if you end up looking at, you look at a patient, what we used to call a EMD or electrical mechanical dissociation. That's what we used to say. I'd see a rhythm. I'd see, for instance, it would look like a normal sinus rhythm, but then when I did an ultrasound, this is what the heart's doing. There's electricity, but the muscle isn't responding. So obviously that's a problem, right? That's why they might not be, why they may have deteriorated. A lot of kids where their heart function is just barely hanging in there, if all of a sudden their atria and their ventricle stop working together. An example of that would end up being children with, sometimes children with PSVT or with ventricular tachycardia, where there isn't, the atrium can't fill the ventricle, and the heart is beating so fast, it can't fill up. There's not enough time for filling, and the atrium isn't able to contract to push blood into the ventricle. If you've lost AV coordination, patients get sick really quickly. And then the same thing, if the rhythm's too fast, what'll happen is the muscle is using up a lot of oxygen, and it doesn't have time to fill. The ventricle doesn't have time to fill because it's beating so fast. And if the rhythm is too slow, the same kind of thing can happen. If your heart is beating slowly, the diastolic pressure is not going to be maintained, And what drives blood into the coronary arteries to help the heart pump is having a high enough diastolic pressure, and the downstream pressure, which is the venous pressure, has to be low enough. So if you've got a heart rate at 30, you're going to have a low diastolic pressure, and often you've got the ventricle is failing and your venous pressure is high. So this is low, this is high, and not surprisingly, not much blood is going to go to the coronary arteries because the downstream pressure is high and the driving pressure is low. So the point ends up being is that with bradycardia, these things are actually contributing to the heart function getting worse, right? Because the muscle isn't being perfused. So those are some of the things that are happening that can lead to a stable heart rhythm becoming an unstable heart rhythm. All right, next slide. Now, let's talk about ventricular fibrillation. So lots of different things cause it. A lot of the time, hypoxic muscle, ischemic muscle, electrolyte abnormalities, there's lots of things that cause it. You know that you've got coarse and fine ventricular fibrillation. I think the point to remember is that both of these are defibrillatable. You can convert them. This is actually easier to convert than this. This is part of the reason that you give adrenaline. Adrenaline can change fine VF to coarse VF, which is more likely to convert with electricity. Now, the thing with ventricular fibrillation to remember, there's primary and secondary. Primary is where I collapse right now. The first rhythm you get, on me is ventricular fibrillation. But if I had asystole as my first rhythm, 15 minutes down the road, you've given 8 doses of adrenaline to me, I go into ventricular fibrillation because all of this adrenaline on top of really ischemic hypoxic myocardium because it's a long arrest. Those are two kind of different scenarios. It's VF, both are VF, but this primary VF is much more likely to convert and have me wake up and walk away, as opposed to the secondary VF. There are not many survivors from secondary VF. It's a sign of a really sick, badly injured heart muscle, okay? So just be aware there is when people talk about VF, there's different kinds of VF. Okay, let's keep on going. So, and do you want me to stop at any point? If you guys have got questions, just stop me. You okay so far? Okay, so far. Slowly. Okay, no good. Okay. Thank you. So, defibrillation, pads, paddles, right? Some of your centers have paddles, some have pads. We've tried to move to pads because what happens is that it's safer, right? It's safer to, we're not talking about putting pads on the chest and paddles on top of the pads. It's easier for us to step away, have the pads on the patient. It's safer for the rescuer to use pads and not paddles. It's also, especially with where we place the paddle or place the pads, like say front and back, what we can do is we're not talking about putting 2 paddles immediately next to each other. There's more space that we've got when we've got these pads that we're sticking on the chest. So there's been more and more of a movement towards pads instead of the paddles. Know what machine you have when you go home. Luca will talk to you about this machine, but this may not be the monitor defibrillator that you have back in your own hospital, right? And I think there are some subtle differences between how they work. And unfortunately, you may not use it often in real patient events. It's probably good to practice with your own equipment so you actually know how to use it. Okay? Let's skip to the next one. So when we're giving electricity, we're giving electricity to defibrillate for ventricular fibrillation or for ventricular tachycardia without a pulse, or we're actually giving electricity, synchronizing it with the underlying rhythm to convert the rhythm, all right? So obviously there's a difference between unsynchronized for VF and pulseless VT and synchronized. Can you give me, what are the rhythms that you think of that we used synchronized cardioversion with? PSVT and VTAC with a pulse, right? There are other ones too, atrial fibrillation, atrial flutter, but the common ones are PSVT and VTAC with a pulse. Why do we synchronize? Why is the machine, because the machine is measuring where the QRS is. Why is it, you notice, Luca will show you that basically you'll notice that there'll be a dot that turns up on top of every QRS. The machine is saying, there's a QRS, there's a QRS, there's a QRS. Why is it synchronizing? Why does the machine synchronize? And it's not just it's more likely to have a good response, it's less likely to kill the patient, right? Because what happens is that if you defibrillate, if you give electricity on top of a T wave, as the heart is trying to repolarize, that's what we call an R on T phenomena. And that patient will go back into VF, ventricular fibrillation, right? So that's why it's really important. The patient with a pulse that you're going to give electricity to, it's always synchronized. Always make sure that that synchronized button is pushed, and that sometimes you have to keep on pushing it for it to synchronize. Sometimes you can just push it and walk away and it will synchronize. Know your machine, I guess is what I'm saying, right? Next one, Luke. So you know that when we defibrillate a patient, what you get taught now is after we defibrillate a patient, we end up starting CPR right away, right? Why is that? Why don't we wait to check the rhythm after we shock? We used to do that. Why don't we now? Anyone know? So the reason that we don't, look, this is what happens after I defibrillate. Luca goes down in ventricular fibrillation. I shock him. I look at what happens with his rhythm after I've shocked him. And what will happen is over 60 seconds, his rhythm is going to change. 70% of the time, if Luca has lots of different events of ventricular fibrillation, 70% of the time, I'm going to defibrillate him into asystole. But what will happen is over that 60 seconds, his rhythm is going to change. 20% of the time, they'll convert. When I defibrillate them, it'll convert into a normal sinus rhythm. But most of the time, it's PEA, right? So really, the problem is, if you check the rhythm right after defibrillation, 95% of the time, there's not going to be a pulse that you're going to get with it. And it's going to change in the next minute anyway, which is why we say, after you defibrillate, just do CPR for another 2 minutes and then check, because it's all going to be changing anyway. Does that make sense? So that's why we don't check the rhythm immediately after defibrillation. And skip the next one. We'll talk about that. Yeah, keep on going. Next one. All right. Drugs with a ventricular fibrillation. You know, in the algorithms for VF and pulseless VT, we talk about the use of electricity, and then adrenaline, and then amiodarone. What you need to remember, kids are not adults with ischemic heart disease. Kids often can end up having other reasons for ventricular fibrillation, like prolonged QT syndrome. What's your first name again? First name? Costanza. If Costanza has prolonged QT syndrome, right? And what happens is she collapses. If I defibrillate her, she doesn't respond. I give a dose of adrenaline. And then 2 minutes after that, I decide to give a drug because I'm doing shock. If I give amiodarone, and you know it's there on the algorithm, right? If I give amiodarone to Costanza, amiodarone will prolong the QT even more, right? So the risk ends up being I may make Costanza worse and not get her out of the ventricular fibrillation or ventricular tachycardia by giving her amiodarone. Now, most patients, you know, it may be fine to give amiodarone. The problem is that if Costanza is 6 years old and playing in the playground and she collapses, I don't know whether or not Costanza has prolonged QT or doesn't. So that's the only caution I'm going to give you is on the algorithm, it talks about amiodarone and also it talks about lidocaine, right? Remember, there is really no benefit of one versus the other, but that may be one of those things. By the time you hit the 6 minute mark, 6 or 7 minute mark, you know, you've given 2 shocks, you've given adrenaline, and you're thinking about what drug you should give next. Maybe you're on the phone with your cardiologist or your reanimation doctor, anesthesia, ICU, and that will be one of the questions that you should be asking is, do I give Costanza amiodarone or do I give her lidocaine? Because this is what the history is, and I don't know if there could be a problem. Anyway, so it's on the algorithm. It doesn't really talk about those details. It's really a pediatric thing, but it's just you need to be aware of it. Does that make sense? All right. Sorry, Costanza. Sorry, Luca, go back. Yeah, great. Next one. I think when you check a rhythm, we've talked about when we check a pulse, you guys know that pulse checks, that bystanders, we stopped teaching bystanders to do pulse checks 20 years ago because bystanders they couldn't do it well. But you know that there are studies that show that doctors and nurses can't do it any better. It's just that we haven't taken away, you know, the ability of doctors and nurses to check a pulse, you know, during cardiac or after, you know, for a rhythm check, right? So the reason I say that is that pulse checks are often inaccurate. Rhythm checks can be really inaccurate as well. There's a study that some colleagues in the United States did that shows that as many as like almost 25% of the time during pediatric cardiac arrests, kids are getting shocked. And when you look at what the rhythm was before they got shocked, it was not a shockable rhythm. So I think just, you know, taking that time, we only know what we know. We always have, do any of you have DAEs in your hospital, or are they all manual defibrillators? They're manual, right? So the manual defibrillator means that Costanza's got to think, is this SVT? Is this a sinus tachycardia? Do I give electricity? Do I not? The AEDs, you know, those are great. There are some hospitals that will use those in the hospital, that will use it as part of their cardiac arrest team. But the problem is those AEDs, if you've ever used them, you know that when you put them on, there are pauses where the AED is analyzing. It's analyzing the rhythm. You have to go hands off. You can't do CPR. And what's happening is that's time where the coronary arteries aren't getting perfused. There are reasons, there are problems with AEDs, okay? But the problem also with the manual defibrillators is that the biggest limitation is us analyzing and making the right decision about the rhythm. I'm not giving you a solution. I'm just saying, be careful, be aware that often we make mistakes. Okay, Luca, next one. Pacing. This is going to be, it's uncommon that you're going to have to do this, but Luca's going to show you how to do it with this monitor defibrillator. It's different with everyone. When you go back home, take a look and see how it works with your own monitor defibrillator. You know, if you've got a hypoxic ischemic heart, the patient is bradycardic 15 minutes into the arrest, you're still doing CPR, they got a heart rate of 20. If you try and pace that heart is like dead muscle. It's not gonna, you're not gonna be able to pace it. But there are cases, there are scenarios where kids do benefit from pacing, and it ends up being these situations, kids that have had heart disease, some children with congenital heart block, you know, with lupus, where if it's third degree heart block, not sinus bradycardia, but third degree heart block, transthoracic pacing may be life-saving. So knowing how to use this, when you start CPR, get the pads on, start pacing them, that heart muscle might respond. And it's not AV, it's not atrioventricular. All you're doing is pacing the ventricle, but you may be able to pace the ventricle fast enough that it actually provides enough blood around the body and your blood pressure rises. So it's a good tool to know about. And Luca's going to tell you about that. And then next one. And that's where we're going to stop. So Luca's going to tell you about the monitor defibrillator, and then we'll talk a little bit more about next steps. Okay? Oh.
Quindi, però lui deve rimanere sempre con le diapositive, deve proiettare, però dobbiamo fare le simulazioni. Quindi restiamo così? Ah, non dobbiamo fare niente. Ok, no, continuiamo così. Vabbè, no, glielo ridò poi lui. Io parlo adesso e poi parla sempre lui. Ok, se vi alzate un attimino, vi avvicinate così parliamo un attimino del defibrillatore. Sentite freddo? Yeah.
Why didn't you turn it on 4 hours ago?
No, it's cold for it's cold for it's cold. It's cold. She feel cold.
Oh, so that's a heater.
No, it's cold. Ma she feel cold.
Yeah, well, sorry.
Allora, defibrillatore, come diceva Allan nella sua lezione, è preferibile utilizzare le pads. Quindi noi avremo qua sul manichino la frusta che si collega al defibrillatore e al posto delle pads adesive come quello del semiautomatico noi avremo questi elettrodi. Quindi facciamo finta che abbiamo queste pads. Naturalmente, se noi non abbiamo le pads, diceva andate a controllare nel vostro ambiente di lavoro se avete la frusta da adattare per le pads, perché spesso i defibrillatori non vengono forniti con la frusta da poter attaccare le pads. Quindi andate a controllare nel vostro calore dell'emergenza come siete messi. Se non ce l'avete, dobbiamo utilizzare le piastre, però sappiamo che le piastre sono molto più scomode, sono molto meno sicure, e quando dobbiamo utilizzare il gel, perché dobbiamo mettere il gel per far aumentare la conduzione, cerchiamo di metterlo in questa maniera: mettiamo sulla sottoclavare destra, giriamo sopra la testa e l'apicale sinistra, perché se noi facciamo in questa maniera corriamo il rischio di creare dei ponti di gel, e dopo che abbiamo defibrillato con le piastre e poi si inizia a massaggiare, questo gel viene sparso sul torace, quindi dobbiamo riasciugare e rimetterlo. Quindi la cosa migliore è utilizzare le pads, e in questa simulazione non utilizzeremo le pads. Il defibrillatore funge anche da monitor, quindi io lo posso accendere. Se vedete qua, mettete la prima tacca e monitor. Metterò gli elettrodi del monitor ricordandovi Gironeve oppure Milan a destra e il Brasile a sinistra. La Juventus non c'è in questa cosa, chissà perché. No. Qualcuno è juventino? Allora, quindi posizioneremo gli elettrodi anche nella simulazione quando dobbiamo monitorizzare, e compare una traccia. Aspettate un attimino che per il momento è un po' disturbatino lui, perché deve rompere le scatole ultimamente. Ok, comunque compare una traccia. Ok, abbiamo questa traccia. Ok? Noi possiamo a questo punto, se vogliamo, se facciamo finta che è un ritmo defibrillabile, ok, compare questa traccia, non fibrillazione ventricolare, ok? Allora io devo defibrillare, devo stabilire i primi jauли. Quindi un bambino che pesa 20 kg, 2 joule per chilo, 40. Metto su 40, noi qua verbalizziamo 40, ma per sicurezza mettiamo al primo step, perché questo eroga. Quindi siamo sicuri. Quindi una volta che io attacco le pads, quindi metterò le mie pads 1 e 2, caricherò, gestisco tutto al defibrillatore, via io, via voi, via tutti, sto per scaricare, scarico ed erogo la scarica. Se io ho un ritmo, che posso cardiovertire, come per esempio una sovraventricolare come adesso, devo mettere in funzione sincro. Quindi ogni defibrillatore ha il suo tastino, questo ce l'ha qua sync, lo premete, si attiva il LED, ma vedete anche sulla traccia si attivano questi puntini bianchi. Questi puntini bianchi stanno a significare che lui si è sincronizzato col QRS e andrà a scaricare sul QRS. A volte può capitare che se si muove, si tocca, legge male, io posso caricare, però non mi carica. Perché? Perché lui ha perso la traccia del QRS, quindi io non posso caricare perché poi non posso scaricare perché non ho letto la traccia. Quindi me lo vado a risistemare. Era la parte... Vediamo se riusciamo. Ok, lui adesso sta riconoscendo un po' sì, un po' no. Vediamo. Ok. È in sincro, si è messo. Allora premo carica, via io, via voi, via tutti, scarico. E in questo caso lui ha scaricato sul QRS. Poi abbiamo la funzione pacing. Se io devo dare un ritmo, quindi trascutaneo, devo mettere, vedete qua, c'è la funzione pacing. Ruoto tutto su pacing e mi si attivano delle due finestre, una che è rappresentata dai milliampere e l'altra che è rappresentata dalla frequenza cardiaca che io ho stabilito di dare. Per esempio, voglio stabilire i milliampere, ok, voglio metterla a 40, stabilisco, attivo il pacing, una volta attivato lui già sta scaricando. E cosa devo notare? Scusate che metto... che così altrimenti non si capisce. Vedo dove c'è questa traccia bianca, lui ha dato lo stimolo e a questo deve corrispondere un QRS. Se io a questo stimolo non ho un QRS che corrisponde oppure corrisponde più in là, significa che non prende. Allora devo aumentare i milliampere. E aumenterò i milliampere, si parte da 30 a 35 e si va a salire fin quando trovo quelli minimi per dare lo stimolo e catturare il cuore. Chiaro? Abbiamo fatto molto veloce perché non abbiamo più tempo. Sì, sì. È molto più, diciamo, responsabile fare una defibrillazione che un pacing. Ok? Puoi toccare il paziente, sì, puoi toccare il paziente. Ok? Ok, questo monitor non mi dà la possibilità di toccare e aumentare il voltaggio o meno. Andate a vedere il vostro defibrillatore dove io posso regolare il voltaggio e quindi capire se è una fibrillazione a basso voltaggio oppure è una fibrillazione grossolana. Sì. Esatto, 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 esatto. Ok, va bene? Possiamo iniziare.
What we're going to do, we're going to go through 3 scenarios. Each of these scenarios, we're going to follow the scenario with a debrief, and the reason for that is that debriefing actually there's good literature that shows that if you debrief, even though you may not have been involved in the resuscitation, being part of the debrief actually helps in terms of how the next patient does. So it actually debriefing. It's not just something that makes us feel better. It actually improves outcome both survival and neurologic outcome of the patients that follow. So it's a good, what I do is every time I end up, am involved in the cardiac arrest, we end up having after the resuscitation, we have a pause and it takes 10 minutes. So it's a good thing to do even when you go home. What we're going to do, we're going to break out into teams of 6. And what I'd ask you guys to do, so we'll start with the first team of 6 people, and if we can try and do it such that there's no more than 2 people from one hospital. So we try and make a team of people that don't know each other. We'll run a scenario. We'll do a quick debrief, it's called a plus delta. What happens is we go from one person to the other that's in the team, talk about the things that went well, and then we go back the other way and we talk about the things that we do differently next time. And then what we'll do is we'll get the rest of the group to jump in and to add in what other observations or thoughts they have. Okay. Make sense? Questions about this? So ultimately, the biggest limitation is who's going to be willing to be in the group, the first group of 6. These are fun. I will say, and please don't feel discouraged. I'd say just make sure that if you're in a group where there's some people that have done PALS, that have done some simulation, because there's a chance it might feel like we're pushing you a little bit, right? This is stuff that's kind of beyond what traditionally you do with PALS, but it's actually to help kind of consolidate some of what we talked about earlier on, if that makes sense. So I'm just saying, don't go running out screaming, saying, "Oh my gosh, I did awful." It's okay. This is a safe place where we're supposed to be learning from each other. Okay. Who wants to go first?
Una cosa volevo dire, quando monitorizzate il paziente potete utilizzare questo modo. Basta fare il touch sulle varie linee e per prendere la pressione premo NDT, premo qua e faccio start. Ok? Ogni volta che voglio valutare la pressione devo fare questo. Ok.
Okay. It's not painful. It'll be fine. Who's going to be the first one? Come on, come on. It's 1, 2. Sure. 6 people. Let's get some. That's great. Thank you. That's great. Okay. So you need one more. Yeah. One more. Come on. Thank you. Thank you, Francis. Okay. So in English, the word that we end up using is voluntold. You were voluntold, not volunteered. You were voluntold. So I'll give you what the scenario is, and then you can decide what role. Right? Remember, these are the roles that you guys are going to break up into in your group, and then we'll do the scenario. Okay. Do you want to do the breakup and assign the roles first? Go for that. Oh, thank you. Yeah, yeah. Grazie. So as we're going through, just do a kind of a running translation. No, you'll do great. You know what? Anything's better than my time. Maybe we should try to make it 7. And I think, yeah, and then we just condense because I guess we've got 65 minutes. It's like 20 minutes per scenario, right? What do you think? 7, 7, 7? Sure. Yeah, I know. Perfect. Yeah, that's great. Okay, so here's the scenario. Okay, this child, 20 kilos, 4 years old, basically has had heart surgery a year ago, right? Now the child comes in 6 hours, 6 hours of increasing drowsiness, mottled, poorly perfused, long cap refill. And the child has respiratory distress as well. The child's come into the emergency department. You're working in the emergency department. The nurses give you these vital signs. Child has a heart rate of 50, does have central pulses. It has no peripheral pulses, weak central pulses. That's the respiratory rate. The blood pressure in this 4-year-old is quite low, right? 65 on 50. Normal temperature. The child is so cold peripherally that the saturation monitor is not working. And that's the rhythm that you've got. So he moans. So he's breathing at 40, he has a little bit of indrawing. His eye opening, what happens is with a painful stimulus, he'll move a little, but he doesn't eye open.
Cominciamo a posizionare il destrino appena il monitor da a fattura o a spiegare diamo un accesso e nel frattempo cominciamo la valutazione delle vie aeree. Le vie aeree sono stabili?
Yes, air is going in and out. No stridor, no drooling. No, no.
Passando la espande bilateralmente.
Yes, both bilateral, symmetrical. Yeah. Because she's bagging, right? And the chest is moving. Yeah.
Vediamo una breve sì, con una contrazione bassa e alto, continuiamo a ventilare, cominciamo il massaggio, vedete sembra funzionare. La prestazione è veramente bassa, possiamo cominciare a fare dei voli. Di precarico.
What is she looking for? What? So it's about that far below the ribs, yeah. Has some crepitations. Yeah. 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 Sure. Yeah. Yeah.
Nel frattempo, io avevo dei punti di precarico, però la passione veramente bassa. quindi siamo 5 ml per chilo, a quanti siamo?
Okay. But pacing it.
Thinking about the 4 inches.
Normal.
Normale, la glicemia è normale.
Quindi con l'emogaffa andiamo a valutare sia se c'è acidosi, se viene elettroliti, lattati.
Allora, pH.
Ah, già è pronto. pH se è 9, l'acidosi, CO2 è basso 10, quindi potassico, sodio 146, potassio 9.
It's the next
Ok,
page.
no. Vibration.
No, this one is just they have to pace. Once they start pacing, then
Sì, okay, they're doing gluconate for the high potassium.
Siamo 2 minuti, fermiamoci un attimo di valutare il ritmo, c'è il polso.
it's weak. It's weak. Yeah, it's weak, still weak. So remember, look at this. Yeah. There you go. Sorry. Look at that rhythm.
Ok.
Yeah.
Quindi ragazzi. Quindi
diciamo le zampe per il legislatore, noi dobbiamo fare il tecnico.
Yeah. So once they start pacing, bring up the heart rate, make it sinus rate of 80 or whatever. And okay, we'll just flip it over to sinus. That's okay. That's still the same. No change. He's moaning.
Is he still breathing on his own?
Yeah. But he is breathing.
They've stopped ventilating him, but they're giving him oxygen.
Yep.
Is they're reevaluating? Are the airways still?
Yep, still patent. Chest is moving. Sorry?
Is the capillary refill time.
Oh, refill. Sorry, cap refill is 5 seconds. Yep. Yep.
It's still going.
Yep.
They-
Yeah. Yeah.
It's improving, the blood pressure is improving.
Yeah. Oh, you can't give it. That's okay. Stop. That's okay. Yeah, they are. This isn't Lucas. The challenge is that the monitor, the upper limit for third degree block is, I think it's an adult. It's adult there. It doesn't allow you to push it higher than 50. So we'd have to make it sinus. Right? That was good. All right. Now, so thank you. That was good. So let's start off. Go. What went well? Just one thing, each of you, and whether it's in Italian or English, I'll get the understanding of what's being said. So just say what went well, and then when everyone said something that they were happy with, that went well with the team, then we can go back and we can talk about what we do differently next time.
The communication was good. They communicated well. Okay, so you're saying that normally when it's sinus bradycardia, you should ventilate for 1 minute before, starting the CPR?
And honestly, if you've got a comatose patient that's bradycardic and they have distress, it's okay to go ahead, whether it's starting immediately, 30 seconds for a minute, just bag. That's okay. That was the right thing to do. Yeah. We'll talk about that. But one good thing. Each of you say one good thing.
Una cosa buona a te, sparare.
There's a lot of good things. There were. Sad when it's easier to think of bad things, right? Okay, do you want to talk? What would you do differently then? What would you do differently next time round? Faster analysis of the rhythm.
No, because they thought diagnosis. They
Oh,
thought
I
it was
see, yeah.
another
And that's
rhythm.
once, and I get, but I think it's always the limitation of the technology and the simulation. But I would say whether it's third degree heart block with bradycardia or it's sinus bradycardia, if they're in low cardiac output state, if they're less than a heart rate of 60, you're going to start off doing the same thing, which is what you did. You said, okay, you started bagging, and then very quickly after you're doing chest compressions, you were giving adrenaline, because whether that's third degree heart block or bradycardia, sinus bradycardia at a rate of 50, it's the same thing. You did the right thing. Okay. The only difference is that as soon as you identified that it could be third degree heart block, in addition to doing the CPR and the epinephrine, it's also getting the pacing pads on to start pacing. But what you did was still right. And there are some times, and stop me if you don't understand me, but there are some times that just getting enough adrenaline and circulating it around the body with CPR will be enough to raise the ventricular rate such that you don't need to do CPR anymore, because the ventricular rate by itself, you've sped it up by giving it adrenaline. The blood pressure may go up, the patient may wake up, even without pacing. But still, ideally, if it's third degree heart block, give the adrenaline, do CPR, but yes, try and start pacing. Identify it as third degree heart block and then start pacing. Does that make sense? Okay. What else? Anything else you do different? We can jump in and otherwise the rest of the team, anything that we think that we should have done, we could have done differently or
It was a little bit confusing, the order in which they did everything. Maybe she
Okay.
thought it was not,
okay.
because they don't know each
Okay.
other. So maybe the dynamics were a little uncoordinated.
That's normal. And you know, in my hospital, all of these people get thrown together, right? And they have to learn very quickly how to work together. You guys, did well. This is different than Latina, where you come together and 6 people have practiced together for months and months. But this is the real world. So that's okay. Yeah, please. Yeah. Yeah. Yeah, go on. So I'm glad so I think, and it was the right thing you picked up on. It was like, okay, crepitations, low liver, ooh, 20 per kilo, no, 10 per kilo, 5 per kilo. But what you were thinking, so what do? You've given 5 per kilo and your heart rate is, let's say your heart rate's 60 or 70 or 80, but your blood pressure is still 65 on 45. And they've still got a cap refill of 5 seconds and what do? You could, but anything else? Because if you categorize, if you think of PALS and you categorize what kind of shock he is, right? Yeah. So I think this is the kind of situation where I think it's the right thing to do what you did to give some fluid, but then also at the same time, you're turning to whoever's on drugs and say, can you please mix up an adrenaline infusion, right? Because I think if this doesn't work, if the fluid doesn't work, we're probably going to need to run some adrenaline. So I think that's where, for me, that's where the category PALS pushes me to categorize. And I say, oh, yeah, cardiogenic shock. Oh, I guess I should be thinking of using some drugs as well. Not push doses of adrenaline, but just the adrenaline infusion. It's great comment. I'm sorry, I interrupted. Were you gonna? No, I'm sorry. Were you gonna say something? Yeah. So it's a good question. And if they're bad enough, like they're in profound shock, atropine, it's not gonna improve conduction because they're blocked, right? So the problem is atropine works well with driving if you have a sinus bradycardia. So if you thought it was sinus bradycardia, you could try. Adrenaline is still a better drug for sinus bradycardia, right? But if this is ventricular, because this was ventricular, right? This is ventricular, right? This is not from the SA node. You know, that's not, the ventricle is not going to respond to atropine. The ventricle is going to get driven by adrenaline, right? So that's where I'd say in this situation, probably adrenaline, which is what you were doing. You were giving push doses of adrenaline during CPR. Adrenaline is the best drug to drive the heart rate up higher.
Maybe we do chest compression.
Okay, what were your thoughts about the chest compressions? Okay, and there are sometimes there's sometimes the chest compressions, were they deep enough or were they too shallow? To make sure who was watching, was there someone that was watching CPR quality? Or that was assigned, or did that go, was it always the team leader? I think if you've got 6 people, think of assign someone to be we call them the BLS coach or the CPR coach, right? And it may be the person that's on the monitor can be giving feedback. Yeah, up at the top, yeah. Can be that person that's saying, right, deeper, faster, don't lean, right? Those are, yeah. Any other observations from you guys? Things that you liked, things that you'd want to do differently? So I think some of the takeaway messages to me were it's, and this one of the previous groups talked about this, that this, even with 3rd-degree heart block, it's almost like you're going down the bradycardia with a pulse algorithm, and that's okay. You're doing that algorithm, but then as soon as you can figure out how to do it, you're starting to pace on top of that as well. And then when the heart rate comes up with pacing, you may not need to be, just with pacing, you may be able to stop giving adrenaline. Everything might be better. I do like the bagging, and as I said, the ventilation, it's, if you've got a patient that's unconscious, that has distress, nasal flaring, and they're in shock, it's okay to bag. I know we're talking about bradycardia and bagging, but even just to say the patient that is not responding, that is poorly perfused, that's got tachypnea and has nasal flaring, yeah, go ahead, bag the patient. That's absolutely okay, right? And I know you were thinking about, well, bradycardia, 30 seconds, 60 seconds, but you know what? This is a patient in distress. Go ahead and bag the patient. Does that make sense? Great, that's okay. That was a good thing to do. Okay, great. We should do next case. Thanks, you guys. That's great. All right, who's the next 6? Just need 3 more. That's great. We're up to 4. 2 more. Come on, guys. This is like, oh. 1 more. Yeah, thank you. Okay. Hey. So let's assign your roles. Take a minute to quickly assign your roles, right? Remember those. You guys must be exhausted.
Yeah, we're a little tired.
I bet you are. It's a
Plus,
long.
I think this is the class where we have to think a little bit more. Maybe we were watching the other classes and this is more practical.
Yeah. Okay. You guys okay? Bene? All right. So this is the patient, okay? This is a child with hemolytic uremic syndrome. It's on your pediatric ward. Everyone, do you remember what hemolytic uremic syndrome is? Does everyone remember hemolytic uremic syndrome?
Okay.
E. coli 0157, Shiga toxin. All right, this child admitted to the hospital yesterday. The nurses have just pulled the cardiac arrest button, and all 5 of you run from the cafeteria. You were sleeping in the resident room. I don't know where you were, right? But you all come running to this patient's room, and you find the child is pale, not breathing, unconscious, and this is the rhythm. Okay. 4. Nope, no pulse.
Yeah.
So they're giving him oxygen, ventilating, and doing this. They're trying to get an IV line.
Oh, yes.
non dipende.
20 kilos.
So they're preparing the adrenaline, but it's a non-shockable rhythm. So they're giving the adrenaline and slushing. Because they want to check for the underlying cause. So they're doing an ETA. Is it this one?
Oh, yeah.
Okay, so they're charging the defibrillator, so they change the rhythm change. $2 per kilo for the first charge. Okay, so she's giving the calcium gluconate for the high potassium. Okay, they're charging the defibrillator, I think. State caricando, raga, io non lo so. It's not reading correctly. The monitor is not reading. Okay. Bye. They want to know if the patient has overload signs.
Nope.
No. Okay, so they're preparing IV fluids 20 per kilo. Is he still unconscious? So they're giving him the second dose of adrenaline. The hemoglobin levels, do we have them?
Oh, 100.
Hemoglobin 100, so 10.
Yeah,
Okay.
10.
Yes.
Sorry. Scusi.
Okay, they're reanalyzing the rhythm. Does he have a pulse now?
No.
No.
Still in BS. Yes. Yeah. Oh, no, no, it's okay. It's okay.
So we're charging again. Sì, ma avete fatto due.
After this one. There's a weak pulse. There's a weak
Certo,
pulse.
forse.
Okay, good. Okay. Let's go go one to one. What worked well? What did you like? Okay. Okay. Mhm. Good.
They alternated doing CPR.
Mhm,
so that
mhm,
they
that's
wouldn't
good.
die.
Yeah. Yeah. Yeah.
The problem was the other members of the
Mm.
so like Eva Becker every time the there
Okay.
and like
So we'll come back to that. That's yeah, I want to hold on to that. We'll come back. Good. What good? Any good things that you wanted to? Okay. All right. So why don't we finish off what you were saying? So you were saying there was conversations here and conversations here, right? Yeah.
no follow up.
Yeah. Do you think, so did you know what they were talking about? Did you understand what they were talking about? Da, 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 da. Not all the time, okay. And that, you know, that's sometimes it's just really important to make sure that, yeah, you're right. You make sure the team leader understands, hey, we're having problems with the airway up here. The chest isn't moving, whatever's happening. Or did you think of maybe we need to treat the potassium? Should we do this or should we do that? You're right. Just make sure ultimately the team leader can help kind of often by summarizing and then asking for input. They'll help get you to give your input. But yeah, if you're at all, if what's happening is if you've got concerns that he's not getting information that he needs, just tell him, right? Which I think is what you're saying. Next time, just make sure he understands that what you guys are thinking. Yeah. But Serena, what would you do different next time? What do you?
It was both ways, like they were only.
Yeah, yeah, okay, yeah, okay. Okay.
Cose negative, farete diversamente. Okay, so the time where they reevaluated the rhythm, rechecking the pulse. So they think that they didn't catch fast enough that it was a ventricular fibrillation. So,
Well,
but I think it changed.
so that was interesting because I think what I saw is that these three were thinking, and these three are going, yeah, yeah, and that's okay. You make sure you say, hey, rhythm change. That's okay. That's okay. Okay, good. Yeah, that's a good point. Anything you want to do differently or see done differently?
So it's before it's done.
before,
Like they did it too late.
yeah, okay. I think, so if you think that the patient is hypovolemic, sure. We'll talk about what was going on in a second. I just want to hear what all of you have to say. Anything? Yeah. Yeah. Okay. Okay. More focused on, sorry, on yeah. Yeah. Okay. Don't forget that. And we'll come back to you in a second. Perfect. Yeah, hyperkalemic, so hemolytic uremic syndrome, right? So often acute kidney injury, potassium, severe hyperkalemia. So they can initially, they can be heart blocked and they can go into ventricular fibrillation. And often it's if you've got hyperkalemia and then you give a dose of adrenaline or 2 doses of adrenaline, it's irritant, myocardial irritant. The potassium is an irritant, and then the heart just starts doing that. Until you get the potassium down, the electricity, you're just going to, ultimately, you'll be doing this so often, it's going to smell like barbecue, right? So you have to get the potassium down. The calcium which you gave is good. It stabilizes the myocardium, but it doesn't get the potassium down. So ultimately, yeah, I think you're right. Bicarbonate doesn't really do anything. So insulin and glucose, getting that in early does make a big difference, right? So and don't wait for. I think you recognized the hyperkalemia at the same time that they said. So it was too late, but still, it's too late to prevent the ventricular fibrillation, but still getting it on board might have actually got you out of ventricular fibrillation earlier. Does that make sense to everyone in terms of what we're talking? So it's the treatment of the hyperkalemia. Ultimately, if it's hyperkalemic cardiac arrest, until you can get the potassium down, you won't get them out of ventricular fibrillation. They'll stay. I do like the, I guess the 2 things I'd say, final comments. One of them is just make sure that you've got someone assigned to doing the CPR quality, right? Because at the time that you guys were thinking, oh, what's happening? What's going on? What's happening is these guys are trading back and forth. They're probably tired. It's the end of the day. They're exhausted. And probably they needed someone to say to them, press harder. Or if you can't press harder, switch roles. Get someone, get Serena to go to compression, and then Maria can go to the airway. Because there was a lot of time where they weren't compressing, they weren't doing deep compressions, right? So someone needs to watch it. Whether it's up here or it's you guys, just make sure you've assigned someone to watch CPR quality. And then the last thing I'll say is, I think that is the last thing I was going to say. All right. So, okay, that was really, really good. Thank you. Thank you for doing that. Okay, we got one more. What's that? No, we are on time. Yeah, but we've got one more. I know. Oh, you're surprised that I'm on time. Sure. Yeah, I know. Okay, 6 more people. We're almost one more case, guys. One more case. If you want to go, you can do it. Or if you'd rather translate, that's okay. This is really helpful to me too. So. It's up to you, totally up to you. Thank you, Costanza. Okay, that's great. 6. All right. So, all right. So decide your roles. Yeah. So this is just synchronized cardioversion, right? Sure, yeah, that'd be great. Okay, you guys okay? It's warm, it is. So.
But the conditioner, it was the AC, it was working.
Yeah,
We switched it off with one.
that's
person
okay.
was-
No, no, that's, yeah, this is,
Because I thought you were
I
like.
know,
why
I was,
didn't they-
listen, I didn't even know that we had an air conditioner that was on. I did, no, that's fine. No, that's fine. No. So that's fine. That's good. Thank you. Good. No, I just, no. What the- No, it doesn't matter. No. Okay. You guys all set? Okay, you ready? Okay. Temperature at home. This is what I'm used to. Okay, so this case, you're in the emergency department, right? This child comes in, 4 years old, 20 kilograms, comes in with 6 hours of becoming increasingly lethargic, is mottled, poorly perfused, cap refill of 5 seconds, weak pulses, and is breathing in the 40s. And this is what your heart rate is. This is the blood pressure in the 4-year-old. And you'll see it there, but this is what the rhythm is. Okay? Go for it. You tap him and he just he moans. He does moan. Yes, at 40 breaths a minute. It's mottled, yeah.
Allora, cerchiamo il polso comunque del quello che diciamo perico debole o centrale. No.
Got a weak pulse. Yeah.
Mentre il modo per vedere
Are the airways clear?
Yes.
Did they hear any noises?
No, sounds normal.
Is it symmetrical?
Yes.
Okay.
la tachicardia ventricolare con un polso debole, però prendiamo una nuova pressione perché il blood pressure del quanto.
Yes, that's the blood pressure. Yeah.
Abbiamo tachicardia ventricolare.
We have a ventricular tachycardia, an unstable patient. And so they want to shock him, but synchronize because they have a pulse. And they're giving him oxygen and ventilating again. Do they get an IV line?
Yes. Sì.
Allora, mette sincronizzata, un joule col filo, ok, a 20 joule, quando ci sei facciamola, non metti su per farlo. Ok,
They're synchronizing the.
ok, carica. Devi scaricare. Ok, vediamo il supporto ossigeno e ancora devi attivare con polso. Cerchiamo il polso.
Does he still have a pulse?
It does have a pulse. Weak.
Debole.
Vediamo ancora.
The refill time?
5 seconds.
Does he have overload like?
So the lungs are okay. What else? What else? did you want to do?
The jugular vein?
No, normal.
So they're debating between defibrillating the patient or giving him drugs. So they are treating him for a supraventricular tachycardia now
Okay,
with the adenosine.
okay.
A quanto, cosa avete fatto la adenosina? Okay, so they're giving him adenosine 0.2 milligrams per kilo, and they're flushing it.
Okay,
And they wanna defibrillate him again, synchronizing it.
what dose are they using?
A che dosaggio? 2 ciao.
La fase all'inizio ed è validata. Ah, ok. Sincronizzato, carico. Via via via. Ragazzi, carico, direi io per tutti.
Ok, andiamo facciamo vedere l'immunizzazione completa.
He's opening his eyes. That's good. Okay. All right. Why don't you talk about what worked well, and then we can talk about what we do differently. So, do you want to start?
They were coordinating and
Yeah.
everything in the right order.
Good. Yeah. Yeah, that's good. Good teamwork. Yeah. Maria? What went well?
They communicated well.
Good. Lucretia?
They debated between the different drugs and then they decided the appropriate one.
Yeah, it's less emergent compared to ventricular tachycardia with no pulse. So you do have the time to be more detailed. Good. All right, Martina?
Okay, they all had their specific role, but still they communicated even
Yep.
if they thought something should have been done
Yep.
differently.
Costanza?
They were giving each other feedback on what they were doing.
Yep, good. Good. All right, and now let's go the other direction. And so, Costanza, so is there anything that you think that the team should do different next time?
Qualcosa che secondo me andrebbe fatto diversamente la prossima volta.
Sure. Okay. Sure, like you've got the time, right? Yeah, yeah, okay. All right. Anything else that you guys would want to do different? All right.
They didn't collect the history of the patient, but in this case,
So,
she doesn't know.
And I think that, and that's a great observation, because we say you've got time, and you do have time to finish up. If you think the A, B, C, D, E, there are probably a few pieces of information in your primary assessment that you could have got more information on. And you're right, the sample history, all of that might have helped a little bit, because you do have the time to do it. Okay, anything else?
Maybe giving him fluids because he had a 5 seconds capillary refill time.
So what do you do about, so he's got 5 seconds capillary refill. So you're saying you think he's in shock, is what you think he's in, right? What kind of shock would he be in, do you think? He's cardiogenic. He may not have crepitations, but he probably does have a liver that's down a little bit. And he is probably cardiogenic. So how are you going to, it's 5 seconds. So we're saying, do you give fluid? Or how are you going to manage his cardiogenic shock? Maybe that might, now if you're hypotensive, that might help you a little bit. And you're right, I think, but ultimately with rhythm causing cardiogenic shock, yes, you can give a little bit of fluid, but the most important thing is control the rhythm. And I like that, what you did with the rhythm, right? Cardioversion first, the adenosine. So why did everyone understand? Why did he give adenosine? Why adenosine? It's why complex, right? You don't answer. He knows why he gave adenosine, but why?
They thought it was a supraventricular tachycardia, a TPSV.
Okay. So you didn't think it was VTAC. You thought it was supraventricular. Okay. But I'm just saying, look at this, right? It could be VTAC, but it could be PVS. It could be supraventricular tachycardia with aberrancy. It could be. So it is the right thing. If it's okay, because if you give adenosine and the heart rate goes from 220 to 140 and it's P wave QRS, you look really good, right? That was smart, right? And yes, it was. That's okay. That's really good. Good. But I think in the same way, and Constanza, stop me if I'm talking too fast or if I don't make sense. In the same way with SVT, that we wouldn't delay electricity to give adenosine. Same thing here, right? If he was getting sicker, I wouldn't give adenosine. I just shock him again now, right? But he was stable. He was okay. That was a good thing to do. That was good. So, all right. Anything else that we would do that you guys would do differently, or anything else that the bigger team thinks they would want to do differently? I did want to ask the group, and this can go out to everyone, not just picking on these guys. Sedation. Would you sedate them?
Conscious. And
Okay.
they,
Yeah.
No, it was my decision, but because.
And I think that was a good decision because. So does everyone understand why we didn't give sedation? Why did we not give sedation to this patient? He was yeah, and so he's unconscious. He's got a pulse, but he's unconscious. He already has a low blood pressure, and you just can give him a small dose of ketamine. Boom. Small dose of propofol. Boom. Right. So there really is no safe drug, and the best thing to do is synchronize cardioversion, right? Don't give him sedation. That was a smart thing to do. If he's awake, if he's lying there and he's awake and he's got a heart rate of 220, you also then can say, he's stable. Dr. Cardiology, or I've got your patient, you better come and fix his rhythm. But you've got a lot more time. You don't have to rush into it. So yeah, go ahead. That's fine. Yeah.
No, da filo di quello, cioè,
Hanno fatto una adenosina e un'altra. She's wondering, according to the pulse algorithm.
yeah.
Okay, bye bye.
sappi che
Unstable.
So I would take the.
To cardiovert him first, right?
Yes,
Yes, okay.
yes.
But I mean, why, the analysis is okay, if, it was,
It was still
So,
unstable.
so I'd say, you've given the first cardioversion, it didn't work. But his blood pressure is okay, he's still breathing. You gave him some help, and that's good. That was good to help him with ventilation. But so would I end up going and go walk to the nursing desk, take 5 minutes to find some adenosine, come back? No, I wouldn't. If I had the adenosine there and I could draw it up in 1 minute and push it,
No,
I-
but the question I think is, if he's okay enough
yeah,
to give him the adenosine, why don't you try the adenosine first and then try and cardiovert? If you cardiovert him right away, then it means it wasn't.
yeah. So it,
Quindi dico, se va bene, teoricamente.
so it wouldn't be, it's not wrong. It's not wrong to start with adenosine, right? It wouldn't be wrong if you've got, in the same way with SVT, if you have a patient that's unstable, but you have it drawn up and you're ready to go, that's okay. You can give adenosine. But it's also, this is one of those things that it's kind of, here's the algorithm and here's the guidelines, and read between the lines, right? Because what it's saying is, I think it's okay if what you're doing is, if you're getting ready, you've just cardioverted, but you're drawing some blood work, you're doing a few other things, you have the adenosine there, wham, you give it, okay, it didn't work, let's give the next dose of synchronized cardioversion. That is okay. That is a real, it's a subtle thing. It's okay to do it that way, though. What's that? Yeah, and you know, there are some, and there are some kids, it's so variable. There are some kids, you cardivert and it doesn't work, and you give adenosine and it will work. And you think, so I think as long as you're not delaying that second shock, you know, if you've got the adenosine ready, give it. I think that's okay. Yes, but once again, cardioversion. But if you look at the algorithm, if you had adenosine immediately available, you could give that too.
But I have a question.
Yeah.
This rhythm,
Okay,
was
yeah.
it attacking the pediatric?
So I think look at this,
I think.
and I'd actually, I'm a symbolize to you, doctor. I'm gonna take a step back and I'm gonna call this wide complex tachycardia. Right now, I don't know for sure. I haven't done my 12 lead. I haven't done my atrial electrogram in the cardiac ICU. I can't tell you for sure whether it's SVT with aberrancy or it's ventricular tachycardia. It's a wide complex tachycardia.
But if they
And
had
on the
given
on the
adrenaline-
algorithm, what's that?
If they had given adrenaline instead of adenosine.
So if you'd
Because they
given,
were debating.
but in the patient that still has a pulse,
Mm.
you wouldn't give the adrenaline,
Okay.
right? If he lost his pulse, that's different. Then that's that's like a wide complex tachycardia with no pulse, right? So I think the point is, though, you're right, don't delay electricity. But if you have immediate access to the adenosine, it's okay, because it might work. If this is SVT, it might work and you'll look really smart. And then if it didn't work, then just give the electricity. That's okay. Not a problem. Any other questions? Yeah. Yeah, you know, this is interesting because I think it's going to be different based upon the department and the hospital, different based upon the hospital. Luca, what would you do? What do you do for sedation for an SVT SVT that needs cardioversion? Midazolam, right? Intranasal, yeah. Now, I'm always am afraid that intranasal, I know there's a lot of people that think it works, but my problem ends up being is that most of my patients they got snotty noses so I would probably give, if his blood pressure was stable, if he's a stable SVT, but I'm going to cardiovert him, I would probably give a small dose of intravenous midazolam, right? If midazolam, intravenous. Ketamine, I think the thing is that's an anesthetic agent, right? So I don't think you need to give ketamine for this all you need is sedation. Ketamine is sedation, anesthesia, and analgesia. That's probably going further than you need to. So small dose of intranasal or intravenous midazolam is probably fine. So, yeah, I guess do you give fentanyl to your patients as well, or do you just give midazolam? What's that? Hey, you just give midazolam, yeah. I think if the patient was needing repeated cardioversion, then you're probably saying you need some kind of analgesia. So whether you're adding in a little bit of fentanyl, if he's maintaining his pressures, or you're giving a little bit of ketamine. I think you always need to remember ketamine is a wonderful anesthetic that they often will end up breathing even though they've had ketamine. But the problem ends up being some patients you give ketamine and they will go apneic, right? As opposed to maybe a small dose of midazolam, you'd be okay. There's no right or wrong, right? If you're going to give any anesthetic, just make sure, do it carefully, small dose. I'll draw up the midazolam or the ketamine. I'll give half of it, watch for a minute, then give the other half, because I don't know whether or not the pressure is going to go from here to here. So, okay, that was great. Thank you, guys. Thank you very much.
Thank you.
Poi